Hi there, this is Marielle Conception, your host of the My DPC Story podcast. Have you or someone you care about ever been burned by the U.S. healthcare system? If so, you are listening to the right video, because if you are listening, chances are the answer is yes. But the U.S. spends so much on healthcare. Why are so many Americans affected personally and especially financially by the healthcare system? Shouldn't that mean we have better healthcare access and treatment options? Shouldn't it be easy for us to be able to see our doctor when we need to instead of turning to the ER or urgent care? Historically, it's been seemingly impossible to answer these questions. But now that is changing through the direct primary care movement. This video that you have tuned into will bring you into the world of direct primary care and show you how physicians all over the country are changing the way they practice so patients from all backgrounds get the high quality care they need and deserve, which makes for both happy patients and physicians. Learn even more by subscribing to the My DPC Story YouTube channel. Find us on all major podcast platforms. Find us on socials at My DPC Story and at mydpcstory.com. There you can find resources including how to find a DPC doctor near you, conferences about DPC, DPC startup guides and advice, a store with DPC swag, and even a mapper showing where podcast guests are practicing. Thanks for tuning in to hear about this powerful movement. Now, on to the episode. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Conception, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
So direct pediatric care, how I like to call it, instead of direct primary care, to me means that you have direct accessibility to me, a board-certified pediatrician. This means that when a parent calls, no matter the time, they get me. When a parent emails, they get me. When they need an appointment same day, they get me. And that means that I get to build a community with my families where we get to know each other. And this really opens a lot of doors in order to be able to learn more about them and what their kids need to keep them healthy. I am Dr. Rosanna Lastra of Head to Toe Pediatrics, and this is my direct pediatric care story.
Dr. Rosanna Lastra is founder and lead pediatrician at Head to Toe Pediatrics, a concierge-style direct pediatric care practice. Dr. Lastra is the first and only pediatric direct primary care provider in the Tampa Bay area to provide house calls for all pediatric health needs. She can handle all pediatric primary care needs that a pediatrician would handle in the office in the comfort of the family's home. Dr. Lastra is directly accessible to her patients 24/7, providing care that is not only convenient and accessible, but also personalized to the needs of the family. She opened Head to Toe Pediatrics in October of 2020. Saludos, Dr. Lastra.
Buenas, mucho gusto, Marielle.
One of the pictures that you have on your website is the multitude of badges that you have had over the years as a doctor. And I wanted to start with, how did you end up transitioning from corporate medicine to your own direct pediatric care clinic?
Yeah, so I will say that it was definitely a process. When I was doing residency, I kind of had the idea that I wanted to open up a clinic or do something that kind of was my own. But when I would talk about this to other people or just commented, I got a lot of that. That's very hard to do. You got to be really sure that you want to do that. A lot of private practices are kind of dying. And going, being bought off by corporate systems. So I kind of put that aside. And what I really liked about my residency was the relationship that I got to build with the patients. So during residency, I was like, okay, I'm definitely going to be doing outpatient pediatrics because that's where you really build the relationships. But every time I was at the hospital, I really liked the thrill of the hospital. So it was like, oh, maybe I should do some hospitalists. But then I was like, no, but I won't get that connection that I feel when I'm in the clinic. So I ultimately decided to go outpatient pediatric route, and I started working at a practice in San Francisco for a big corporate organization. And I was doing mostly outpatient, and I was enjoying it, but I definitely noticed that after the first year, it was different. Definitely working outpatient as an attending versus a resident is a completely different view, a different perspective. I didn't like feeling like I was rushing through appointments, especially like if a patient showed up late, but you're booked into certain time slots, you can't really spend the time to really get to know the families and build that community that I really appreciated during my residency. So I started to think a little bit more about, I really liked the hospital setting. And one of the benefits of a hospital setting is that the patients are at the hospital all the time. So you could spend time with them because you can kind of dictate your time versus having the time being dictated for you. So I started picking up extra shifts at the hospital and doing newborn rounds or seeing patients. They also had some like NICU shifts that I could pick up. So I would do those during the weekends or if it was during a holiday and they needed additional help. And I started to really like that. But over time, trying to do that plus trying to have a clinic, you just have no time for anything else. And I didn't like that lifestyle either for being able to spend time with my husband, talk to my family, take trips. So that's when I decided that I was going to quit and try to figure out what I was going to do. So I remember I was talking to my husband and it was completely out of the blue. And I was like, I am not feeling really happy. So I think I'm going to quit. And he was like, okay, go ahead and quit. And I think like literally the month right after, I was like, I'm quitting. And I was like, wait, what? So yeah, that was a big moment because I did not have any plans as to what I was going to do other than I was going to quit. So I was like, I'm going to quit and I'm just going to travel the world and I'm going to take this time to just really enjoy it and figure out what I'm going to do. But I'm very type A, so I really like having plans. So that was really, really, really hard for me to do. And I started applying to locums companies and I applied to a few. And then that's kind of when I went on like this full-time locums tenens path. And through doing that, I started to really understand more about what I liked and what I didn't like. And I think having all of those experiences together was kind of what led me to understand what I wanted to do for my own practice. So I was doing locums tenens, traveling all throughout the United States. That's where that photo of the multiple badges come from. Then 2020 hits and here comes the pandemic. So you can't really travel much anymore. Although at the beginning, pediatricians weren't very much thought of. So a lot of the travel assignments got canceled. And I actually started helping a clinic in the area that was needing some additional coverage. And by this point, we were now living in St. Petersburg, Florida, because my family lives in Tampa. So when we decided to travel, we wanted to move closer to family. So when the pandemic hit, like I said, some of my travel assignments got canceled. I wasn't really feeling comfortable with traveling, so I didn't want to continue to apply to any more. And I decided to help at this outpatient clinic. And while I was helping at this outpatient clinic, I started to see a lot of the struggles that families were having. Patients were not coming in. Parents were scared to bring in the kids. They felt unsafe in the clinic setting. And that kind of really opened my eyes into, well, what can we do to provide better care for these families? Because we're doing a lot of telemedicine and transitioning to telemedicine. That doesn't cover everything that families need at times. And it doesn't help alleviate the stress, because there's definitely something different when you're talking to a doctor by telemedicine versus when you're talking to a doctor in person. And now some of these patients, I obviously was a covering provider. So it wasn't that they knew me as a physician. I was just this covering provider they've never met, giving them advice through telemedicine. So it's like, how do I know that this is good advice? Or why should I trust this doctor that I've never met or I don't even know, in addition to all the stress that I'm feeling because of the pandemic? So a lot of those barriers just kind of started to pop up more. And in thinking about ideas, I thought of, well, if families are scared to leave the house, why don't we go to the home? And then in researching how that could be possible, then I started to hit a lot of hurdles in terms of insurances don't cover house visits, and we can't do house visits, and there are too many patients that we may need to be available in clinic for, so that's not a possibility. And just thinking through all of that, I started to look at, initially I was like, well, what if it's a concierge model where families are paying for the service in addition to like maybe using some of the insurance? So I went down that route, and in doing a lot of Google search and posting on some Facebook groups, that's how I learned about DPC and what the direct primary care movement was. And then I got connected to a pediatrician specific Facebook group on DPC. And that was super eye-opening after seeing what some other colleagues around the United States have accomplished through the DPC model. Knowing, thinking back to my residency days when I was like, maybe I do want to open up something on my own, but not knowing what that could look like. All the kind of windows or doors started to open, and I was just like, okay, this is what I'm going to do. And I think I can do this. And so I opened head to toe.
And you are a pioneer in your area because there's no other physician-run pediatric practices in St. Petersburg. Is that correct?
Yes, that is correct. So there's no other ones that are doing all home house calls for well and sick kids in the area. Through the DPC group, I did meet another provider who opened in Pinellas Park, which is about 20 to 30 minutes from where I am, but they're in a clinic setting, primarily doing in clinic. They do offer some house calls. I'm not sure of the extent that they're offering their house calls, but they started, I think, shortly right after me, and we've actually been communicating back and forth. But yeah, we didn't know each other until we had both opened, I believe, until we were both about to open. I don't recall the timing exactly.
And with you being, new to the area in terms of bringing the model of home visit, direct pediatric care, as well as clinic-based direct pediatric care to St. Petersburg and to the Tampa area, what are some common questions that you get from patients when you're educating them about the model? Yeah.
So I will say for the patients and the families that I've talked to, if it's all been revolved around the house calls. So I haven't really had any questions in terms of the clinic setting, but the most common question I get is, you do house calls? And it's been a lot of education, because a lot of families, of course, don't know that it's now a service that's available in the area, and they don't understand how it works. So it always starts, do you do house calls? And then how does that work? And then after that, but do you accept insurance? And that's kind of when then we go into the direct pediatric care model and what that means. And I will say, I still feel that families are not fully understanding of maybe some of the benefits that the direct primary care route can offer, even if they have amazing insurance. So right now, families that either have insurances with very high deductibles definitely are like, oh, this is great. And you do house calls. This is amazing. I'm going to definitely look into this, ask for more information, look into the services. Families that maybe don't have insurance either because of a gap in time. Commonly, I get like newborns. So like if parent knows that during that first month, it takes that first month for the baby's insurance to kick in, and they're just like, I really don't want to deal with the stress of like calling, transferring the child, figuring out where to go see them or how that insurance works during that first 30 days. And not be able to have someone accessible that I can ask questions to, like that's just really stressful for me at this time. So I just want to go direct to primary care route, either, for the first year of that baby's life while they settle in and then kind of figure out the whole insurance. That's kind of another family group that I'm seeing that tends to really enjoy that house call model, especially with the babies. They love the idea of not having to take them to a clinic and be exposing them as well.
Stay with us. We'll be right back. My DPC story just hit 100,000 downloads on Apple Podcasts alone, and we could not have done it without our amazing listeners. So to thank you and to celebrate this milestone, we're giving away an incredible DPC Summit prize package for the DPC Summit happening in Minneapolis this summer. The prize includes My DPC Story swag, and on top of that, the prize also includes a ticket to the DPC Summit. Check out my interview with Dr. Jeff Davenport, where you'll hear more details about the summit. To be eligible for this giveaway, all you have to do is first rate and review My DPC Story on your podcast listening platform. Pro tip, if you rate My DPC Story with a 5-star review, it helps the visibility of the podcast and it helps others to find all these DPC stories. Number 2, take a screenshot of your review and email it to support@mydpcstory.com. You'll find that email in the show notes as well. And third, make sure you're following My DPC Story on all your social media platforms: Instagram, Facebook, TikTok, YouTube, LinkedIn, and Twitter. All the social links are at the bottom of mydpcstory.com and also in our show notes. For bonus points, share both this episode and the My DPC Story posts about the DPC Summit with your community. The winner will be announced in a future episode, so make sure you tune in to find out if you'll be heading to the summit. If you've already purchased your ticket and you're the winner, My DPC Story will send you a check for the price of your ticket. Thank you for listening to My DPC Story, and best of luck. Absolutely. As a mom with a 3-month-old, I understand where those parents are coming from completely. So let me just ask you, having heard the families that have become part of your practice ask these questions, I'm assuming that you used the answers that you were commonly given to educate your patients to also make the content for your amazing videos that you've made yourself on your website.
Yes, I definitely have. So I have a few videos that kind of educate on the direct primary care aspect. So I have one specifically that I call direct pediatric care. And it kind of talks about the difference between the insurance model and what direct pediatric care is. So it's great to have it as a reference for some families that are still like, well, I don't quite understand. And then I show them that. But I will say a lot of it is repetition. What I've noticed helps with families and understanding. So they may talk to me and ask me about it, and I'll tell them about it. But then I send them the video and I'm like, oh, okay, I understand it a little bit more. And then they may then follow me on social media, Instagram or Facebook, and I'll post about it every once in a while. I'll put it on the stories. Actually, for the month of March, I'm going to be doing, my topic for the month is going to be about us. So I'm going to be doing a lot more about what direct pediatric care is and what benefits families can have from that. So little trickles of information here and there, because I've definitely noticed that in the area, there is not a whole lot of education and understanding. It's funny because when I first started promoting my practice, I would promote it as like, yeah, we do house calls for direct primary care, concierge style. You should definitely join. And that was not getting me anywhere. But then when I kind of switched to, let me educate you about this. Do you know what direct primary care is? And this is why it could be useful. And by the way, that's what I do. And this is my practice. It got the conversation going a lot more.
Especially how you were mentioning, families wanting to have care as much as they can at home. I can easily see how that's possible. Now, I want to highlight the other videos that you have on your website. I mean, you did. I was cracking up at your introduction to your practice video, where you have Mickey and Minnie Mouse and your amazing marionette, and when you cut to the scene of on the floor when the toys needed to be picked up at the end of that video. I apologize for spoiling it in terms of the ending of it, but
now everybody has to see the video. Just don't skip to the end. Watch it from the beginning.
That's a great way to put it. And when you listen to Mickey's ear, that was genius. Can you share about how you go about creating these masterpieces?
Yeah. So I will say my biggest benefit is probably that I want to be lazy when it comes to the videos. And by that, what I mean is I like to do a lot of things for the practice, but everything requires time.
So I can either spend time learning about all the intricacies of creating perfect videos, or I can use that time to do other things to continue to expand the practice and just take the videos as they come out and just make them funny.
And actually, the heart being in the ear was because I couldn't get the marionette to actually move to the place that I wanted her to be able to place a stethoscope to listen to the heart. And then my husband was actually helping me with Mickey's voice. So he was just he's like, oh, you're listening, my heart's in my ear. And I was like, we'll go with it. We're like, sure, yes, oh yeah, your heart's in your ear. And I was like, I do not want to edit this video because editing is going to take so much work. So we got to go with whatever happens first. And that's how they become funny.
Definitely, you have achieved that, because I was cracking up at that video. The graphics that you use in your videos, like the secret agent video, for example, that one has incredible graphics. And do you use a particular video software when you are putting them together? I can tell from some of the titles that it looks like iMovie's being used.
Yeah, so I use iMovie, and they actually have like trailer templates, and you just put in photos and videos, but they do everything else for you. Going back to that, just trying to be lazy part. So it was one of their templates with the special agent one. And you as you read through the template, it tells you the storyline. So then I was like, oh, that would be a good photo for this part. Oh, that would be a good photo for this part. But then, of course, it was not like special agent for medicine or a doctor. So then I had to change. It allows you to change some of the wording. So then I changed some of the wording. But thankfully, there was like a template to follow, which made it easy. And that was great.
Earlier you mentioned how you transitioned from pediatric hospital medicine to working in an outpatient clinic for a corporation, and now being a trailblazer and opening your own clinic in St. Petersburg in the model that you've developed. I want to ask about your patients. In terms of the patients themselves within your pediatric age group, are you seeing more of a certain age, and how is growth happening for you?
I would say I'm probably seeing more newborns than I am older kids. The older kids that I've picked up have been either siblings from the newborn, or that they found me through someone who I had talked to because of their newborn. So because I feel that, especially if they're a first-time parent, those are the type of families that can really benefit from the service in terms of being able to have 24/7 access to me to ask questions, because first time parents always have a lot of questions. So it's a little bit easier to kind of start a conversation with those families. And the other reason is they may not have chosen a pediatrician yet. And a lot of pediatricians in the area do not offer meet and greets, but I offer meet and greets. So it's a great way for families who are looking for meet and greets, and they search or they talk to someone like, oh, who's doing meet and greets? It kind of sets me apart in a sense. And that's why I've kind of been targeting that group.
Because you opened in October of 2020, how do the meet and greets go? I'm assuming virtual?
Yes. So all of our meet and greets are virtual because it also allows a way for kind of us to communicate with each other, see each other virtually before we're going to their home to do a meet and greet. Post-pandemic, I think I would probably still continue them virtual. Maybe consider doing some like group meet and greets with smaller groups in a like central location, but we'll see where that goes.
As part of your practice right now, you continue to do newborn rounds in the hospital, correct?
Yes. So that's my side gig. So I'm actually a pediatric hospitalist for an area hospital. And that is aside and unrelated to my direct primary care practice. When I was doing the locums work, I realized that I really liked working in more of like a community hospital setting where you're kind of on an on-call basis, where you go in, see your patients, and then you're just on call. So it's that same setup, which works wonderful for me, especially with growing my DPC practice, because I only have to go to the hospital, see the patients that I have for the day, and then I leave. I'm not like on a shift schedule where I have to be there a certain number of hours. And that has been very nice. It also allows me to keep up my skill sets. And I feel like it also gives me a better understanding or to be able to counsel the families, like if their child does have to go to the hospital, knowing kind of both settings and being able to educate them on what to expect, or being able to say, you know what, this really needs to be seen at the hospital.
And what about for newborns? Like you mentioned, some don't have a pediatrician yet when they are discharged. How do you connect with families after a baby's born if you were in, for instance, not at the hospital while they were born, or if there was a home delivery?
Mm-hmm. So the families that I see at the hospital are not families that I typically send to my practice, or I'm like, oh, or I don't really gather them much from the hospital. It's because most at the hospital that I work, there is a lot of, everybody has very good insurance, or they may be on Medicaid. I get a lot of Medicaid patients. And as part of my DPC model, because I still work at the hospital, I can't decline my Medicaid privileges. So I actually cannot see Medicaid patients. So because of that, I don't really promote much of myself when I'm at the hospital. I just kind of have conversations with the family. I don't want them also to feel like I'm encouraging them to like choose me as their pediatrician. So I more so educate them on things or qualities that they need to look for in a pediatrician in order to know how to choose the right pediatrician for them. And the way I like to take it is I ask them, like, what do you want in a pediatrician, or what's really important to you? And then I make a recommendation on what they say, if it's someone that I know, or if I may be a good fit. But I usually try not to talk about myself much. If families like me, they usually remember my name and they Google me, and then that's more so how they find out about me. For home births, I have connections with a few midwives in the area I've talked to that I personally know, that I trust, that I know their methods, that we can easily communicate back and forth when there may be a concern or an issue where we're like, this family is probably better suited at a hospital, or these are some concerns that I have. If the family is doing a home birth, these are things that I want to make sure we're kind of checking off. So having that communication makes me feel a little bit better about patients who I see who come from home births. But the patients that I get from home births that I accept are from those midwives that I do have a connection with and that we have a personal relationship.
And I would think that would help also in terms of just knowing more about prenatal care for the child.
Yes. So it helps because we're, instead of like contacting me after the baby's born, hearing about them during the time, maybe like a month or even 2 before their expected due date. So if things come up, for example, something that we may frequently see is GBS, if a mom is GBS positive, and the family may be considering not doing antibiotics or things like that, then I'm able to talk to them and we kind of address some of those concerns so that parents have evidence-based information and all of the information that they can have in order to make those decisions for their children.
With that said, I'm assuming that parents will listen to you differently, especially if they know that they can follow with you after the child's born and they're not having to just take a one-off opinion of a doctor that they don't really know.
Exactly. So it just helps in building that relationship. And it also helps because they obviously trust their midwife a lot. It's someone that they chose to go through that journey with. And knowing that me and those midwives can also have like a clear communication and we're able to discuss when we have differences, and them seeing that also helps to build that relationship.
In that situation where you're discussing a patient's case with a midwife, do you tend to keep it general so that you're not at all, getting close to HIPAA issues?
We would so those scenarios are only with patients that have already chosen to pick me as their pediatrician and we've signed a contract. But before the baby is born, we do keep conversations general because I don't have a patient yet. So it's more guidance and here's places where you can look for more information. And this has been my experience. But yes, it's not a patient-doctor relationship until the baby is born.
What a different space to be in. I had never thought about that until, as you're talking about the relationship that you have with midwives and the families and how that all works together.
And I feel like, some doctors will probably be like, oh no, I don't want to talk to them before or anything like that. But there are some life-saving things that could happen. And if parents just feel comfortable talking to someone, they may not even be looking for medical advice, just talking to someone who they feel comfortable with, it could really change. Like a big example is vitamin K. If a family's undecided whether they want to use the vitamin K or not. Whereas if I'm waiting for me to come in after the baby's born, kind of all those decisions have already been made. So that's why I have enjoyed being able to have those discussions. And another great example is earlier this week, I was talking to a midwife, which we've become friends, and it was just random conversation, not even patient related, but she's like, hey, I want to know more about the newborn screen. Can you tell me a little bit more about that? So also being able to have those kind of discussions with these providers, where you could communicate about all those things, then I feel ultimately who's helping is the patient.
Definitely. And I can imagine the impact that you're making, not only for the kids, but also for the community, because as we're very aware of, there's a lot of information out there that's not correct or not up to date. And so the idea that you're putting yourself out there in the community at all stages of a child's life, in utero, when they're newborn, and also talking with these midwives who are taking care of families at different stages as well. So I think that's really powerful that you're really affecting potentially generations.
It's a lot better to practice in this model because I'm not I don't have to be oh, I can't do this because of that, or I can't do this because the group doesn't let me do it, or I can't be out on my own. So it's a lot more fulfilling as well.
When you talk about doing it on your own, one of the things that a lot of people are gun shy about in terms of deciding to actually jump into DPC is the 24/7 call. So how has that been for you as a solo practitioner doing pediatric care?
So it has actually not been bad at all. I've been used to the 24/7 call during the locums work when I would pick up some shifts like at the community hospitals, like I mentioned, or I would be maybe on a 10-day stint on call. And I got called there a lot more than I get called now. I actually, knock on wood, haven't had a family call me in the middle of the night. And I attribute that because of the relationship that we're able to build. Even like now when I tell some of my family, it's like, oh no, we're not going to call you at 2 a.m. to wake you up for that. They're like, no, you need to sleep. And I'm like, oh, thank you. But you can call me, like call me if you need to. But I think the fact that they know that if they call, they're going to get an answer is huge, right? Like I think parents stress when their child is sick at 2 a.m. and they know that if they call, they're going to get an answering service and they may not get a reply, or they may get to a nursing line who's going to ask a bajillion questions, tell them to go to the ER. So they're like, I'm just going to go to the ER because I don't know what to do right now at 2 a.m. Versus my families are like, well, we know Dr. Lastra is going to answer. So is this, I think when you bring down that stress level of being like, I'm not going to be able to get a hold of anyone right now, I think bringing that down, then they're like, well, does this really need to be called in right now? Let me think about this. And then if they're like, it probably does, then they know they can call me and I could be like, yeah, that needs to go to the ER or not. Or they may be like, this can actually wait till 6 a.m. because I know, again, Dr. Lastra is going to answer at that time. It's not going to be waiting days to get an appointment to get my concern addressed. So I think taking away the stress factor really helps in not getting those 2 a.m. calls. And also, my visits are not 15 minutes. My visits are an hour to 2 hours, depending on how long the family needs me to be there. We do in-depth developmental evaluations. We answer all of their questions. I actually educate them. It's not like, here's your handout and make sure fever of this call, funny breathing like this call, or, it's not that fast. It's like, I can actually spend the time to be like, well, this is what we look at. This is the fever. This is how you take a temperature on your baby. And this is when you would want to take a temperature on your baby. So I can actually educate better. And when parents feel like they know what to do or they know what they're looking for, they feel more empowered about their child's healthcare. And I think having that also makes them feel better about knowing that they can handle some things, and then they may not necessarily need to call me at 2 a.m. for some smaller issues.
Just thinking back to the days when I was a first-time mom, the medical brain just completely shuts off when you're an exhausted parent. But the idea that just thinking back into that space of, oh my goodness, I've learned about this in books, but I don't actually know what to do. And to then think about a parent who is having those same feelings without any medical training, potentially, I can just imagine how wonderful of an experience that is for them to just be able to pick up the phone whenever they need you and to be able to get an answer right away. I think that is just, it's incredible and it's what everyone deserves, but I'm so glad that you are bringing that service to your families. What EMR are you using for your practice?
I use Charm Health as my EMR, and families can communicate through there. They can email me. I pretty much leave it up to the families, and I ask them, like, how do you prefer to be contacted, or how do you prefer to contact me? Some families say text, and that's my way, and I'll do that. Other families are like, email, that works better for me. Other families are like, I wanted to use the EMR all the time, and that's what works for me. And other families are like, I'm on social media now, so I'll just, if I need something, I may contact you on social media. So I, of course, warn the parents that anything outside of the health record is not necessarily like 100% secure, and it's not HIPAA compliant. So if they're engaging in that way, if it's something more personal or medically, just something that I prefer that it goes through the EMR, that I will answer through the EMR and then text them like, I sent you a message through the EMR, check that. Or if it's something that it's just like, hey, can I reschedule my appointment? Then I answer through whatever method they contact me.
If a patient's family contacts you through something like social media, like Instagram Messenger, do you take like a screenshot or do you reference, hey, you contacted me on Instagram about XYZ problem before you answer their question in the EMR?
So you mean like how I document when a family contacts me through social media?
Yeah.
So I will not answer any medical questions through the social media. So if I'm answering through social media, it's like example, like, can I rebook my appointment? Or I will say a lot of times through the social media, it's just that families that like to be social, they're just kind of tagging me on their stories and being like, oh my gosh, look how cute he's like holding his bottle now, or, stuff like that. But I will just say, I will message you through the secure portal as a reply. And then depending on what the question is or the concern is, then I also document on the EHR family contacted. This is what happened. I replied back, checked the patient portal messages for details.
In terms of communication and marketing purposes, you use Mixmax as a service as well. Can you share about your experience with Mixmax and how are you tailoring it for your clinic?
So I've enjoyed different aspects of Mixmax. One of the ones that I find very helpful is that I can personalize my signature a lot better than I can with any of the other like signature services that I've used. So I really like it for that. And it makes it easy to keep it updated. And I also really like it for being able to set up reminders and templates. So like if I'm onboarding a patient, for example, a lot of that is a lot of the same thing. Like here's the contract, here's the next steps, et cetera, et cetera. So having templates for that is super easy on Mixmax to just kind of click on the template and then you can edit it as you need it. So I like it for that. And I also like it for when you're talking to someone and you're like, hey, let's set up an appointment. It's super easy to put in like your Zoom link and like schedule and share your calendar. So all of those things have been the things that I've really enjoyed from Mixmax. But I will say the calendar, I use it sparingly. I do like Calendly more for calendar booking, which I include as part of my signature on a link. And it just looks prettier on Mixmax, I find.
Having seen one of your emails before, how easy is it for you to put one of your videos in as a signature for your email communication?
Oh, it would be very easy. Yeah, I could put that in. I have one of the videos right now as part of my signature, but not one that I made, but one that I interviewed. I don't know, actually, that's a link. But yes, I could upload the YouTube very easily on there.
I want to jump to vaccines because one of the things that you do also offer for your patients is bringing vaccinations to a patient's home. So can you share more about vaccinations, how you obtain them and how you administer vaccines, especially those that might need to be frozen or kept at a certain temperature?
Yeah. So I am very lucky to have some very close friends who are pharmacists in the area who work with amazing pharmacies that are more local pharmacies instead of, bigger pharmacies. So they have been super helpful in helping me with the vaccination. So currently what I do is they order the vaccines for me. For anyone who is 3 or older, I can send it in as a prescription and they can get it individually for that patient and then it's covered through the family's insurance. For those who are less than 3, because technically, like pharmacy laws, they cannot dispense to less than 3 when it's vaccination, then I buy it as a provider from them and they sell me, in that instance, I have to buy like the box. So they sell me the vaccine and then I administer them. So in that scenario, I could either bill the insurance. I tried to do that, but that was a big headache. And I gave up on that. I was like, this is not going to work. So I have just been taking that cost myself and I have not been charging the family for that. But I know with time that's a very expensive cost and I'm not sure how that would transition on. So I heard about a lot of people that use VaxCare, and VaxCare is a company that kind of sets you up for vaccines in your clinic. So they give you the equipment, they provide you with the vaccines, and they do the insurance billing. So a lot of the issues that I've had with insurance billing with DPC, at least for the state of Florida, and the insurances that I've tried to contact, is that they do not contract with direct primary care doctors, not even as out-of-network providers. So that was a little bit of a roadblock. But with VaxCare, they are the ones that would be doing the insurance billing, so they would still be able to have the family insurance be processed to be able to bill for the vaccines through the insurance. So I actually just got approved this week, which I am super excited about. Because it will really help with that gap from the 0 to 3. But since they'll be setting it up for me where I am, I'll actually be able to just do vaccines for everybody through VaxCare. So my pharmacy friends have kept the current vaccines that I bought from them in the refrigerator very kindly, and doing all the temperature logging and monitoring, since they already do that for their own vaccines. So, and then the extra nice part, which I'm really going to miss, is that they do home delivery for the vaccines for me. So we coordinate the time, and they take care of, continuing that temperature monitoring and keeping them in the environment that they need to be kept at before they're administered. So we coordinate where I'm going to be and what time I'm going to be, and then they meet me there with the vaccines when I'm about to vaccinate the patients. And that's currently what I've been doing. So with VaxCare, I won't be able to do that because they'll be with me. So I'll have to dig a little bit more about the process for transportation for that. So I've been spoiled.
I just think about my husband's cousin who was an expat in Panama for, 3-4 years. And the way that vaccination is set up there is the way that vaccination was set up for the yellow fever vaccine for kids was all home-based. It was not, you go to a clinic and at least their specific family care was set up through home visits, and it wasn't through clinic only visits or pharmacy only visits. And so I think that, that's wonderful that you've worked, closely with a private pharmacy and your friends who run the pharmacy there. But it's interesting how things are done so differently around the globe, and something that's very normal in a place like Panama is still foreign. It just goes back to the education aspect of your patients and your families. When you get VaxCare on board 100% of the time, what do you envision, because you are doing a home visit model, what do you envision for your vaccine storage? Like, are you looking at a particular model or product?
So I am going to start looking this week at what refrigerator, temperature monitors, and all those things I'm going to be getting. And I've asked my pharmacy friends for some suggestions, and they've sent a few to look at. And also through the DPC Facebook group, a lot of people have posted there of refrigerators they've gotten. So I just have to kind of go do some digging on those blog posts to get a better sense of what may work for me. But I think one of the things that I'm really looking forward to and able to do when I get back here is being able to set up drive-through vaccine clinics, or clinic days where I can offer vaccinations for patients who are also not members, because I've actually been getting quite a few calls from some families who are like, we love our pediatrician, but right now with the pandemic, we're concerned about going to the office, but they don't really need any checkups, but could you do vaccines for us? Because we don't want to go there to do the vaccine that they're due for, and they're delayed. So I hope that I'll be able to bridge that gap as well.
Rosanna, in relation to home visits, one of the things you had mentioned on a previous interview was you have a toolbox. And with you doing home visits, I'm interested to know, what is your toolbox and what's inside of it?
I have a toolbox. It's literally a toolbox, where you go to Lowe's and those toolboxes there to put tools. I use that as my house kit. And in there, it has 2 levels. I actually did a video of what's in my toolbox, and it's on my Instagram. I still have to upload it to YouTube, But I have 2 levels, and then I kind of put the upper level as my like well visit upper stuff in there, and then the second level or the lower level is kind of things that I need for sick visits. So I have for well visits, I have my stethoscope, my weighing machine or my scale, things to get measurements and height on the kiddos. I have my pulse oximeter. I have my blood pressure monitor to get blood pressure. I feel like I have to be looking at it to tell you exactly everything that I have in it. But everything that you think of, things to do vision screening, hearing screening. My pulse oximeter does hemoglobin screening, so I don't have to poke kids to get a hemoglobin screen if I don't need to. I could do that through that. And then I have, of course, like gloves, masks, hand sanitizer, all those goodies. And I'm sure I have more in that area. But then in my sick area, I have all swabs that I would need to do strep, flu, RSV, COVID testing. I have urine cups to do sterile urine. I have P cups for non-sterile urine samples and for checking protein for like a well visit. I also have glucose meter to check glucose. I have medication samples, and I have anything that I may need, like Tylenol, Motrin, or an allergy medicine, epinephrine for when I get vaccines. And I have a little area kind of in front of the toolbox that has a little area that it's kind of like a little craft boxes, so it can clip out. And in there, I kind of put things that I use for procedures, so like scissors, stitches, alcohol swab, extra batteries for when one of the things that I use, like the scale, the battery dies, or the pulse oximeter, which also requires batteries. And I have ointments, like if I need to use any ointments for stab, burns, anything like that, dressing. I have masks for CPR for kids, adult size, and babies in case they have to do any resuscitation. God forbid with any reactions to medications or anything like that. Just more kind of like an emergency, just to feel comfortable that I have that. But knock on wood, I won't have to use that ever. And I think those are the main things that I can think of. But I'm sure I definitely have more things in there.
In terms of the education of your patients and their families, how does the home visit allow you to educate differently than you would in an office?
I think one of the biggest things is that we're not restricted by time. So we can discuss a lot of things in more detail. But one of the other benefits is that I'm in their home, I'm in their environment. So I can direct my education based on things that I'm seeing around the home. So big educational topics that are always discussed are like nutrition and sleep. So with nutrition, when we're talking about nutrition and healthy eating and healthy habits, we can actually be like, well, show me what are some things that you eat on a regular, or let's go to your pantry and see your refrigerator. So you're better able to kind of target and understanding where the family is at and what their goals are. You can maybe say, maybe you can substitute this for this, which could be a healthier alternative, but it's just the same as this that you have here. Like a great example is like yogurt. People don't really tend to look at nutrition labels for yogurt, but they really differ. And some of them, even for like the same, I tend to eat like plain yogurt. So I'll look at labels of plain yogurt. So little things like that I'm able to pick up where you're not really changing much, but you're at least doing a small change that's towards a healthier lifestyle. Sleep, when it comes to sleep, I can see, well, there's television in the room. Maybe we may consider taking that out. Or, what is your sleep routine? Can you walk me through it? And when they're at the home, they're like, actually, yeah, we go from here to here, and then we do this, and then we do this. We read, if I don't see any books, that may be something I may recommend or ask, or like, why are there no books? Or so it just leads for a whole lot more of discussions, which ultimately allows for more education.
Perfect. With you being a sole practitioner, you mentioned charm earlier. Can you talk in more detail about how you handle medical records, and what medical records do you request when you're onboarding a patient?
Yeah, so I do everything through charm. You add a patient kind of like you would in any other medical record, and then it creates a whole chart where you can document when you do visits, you can make appointments for the patient, you can upload documents. So in terms of what you can do almost anything that you can with another EMR. It's just sometimes you may need to do extra steps, or you may need to do it in a different way, or something may be recorded in a different unit, for example, with like the growth chart. So in terms of that, there hasn't been much of a change. What I do when I onboard a patient is I start with an agreement. So that agreement is sent for them to be able to sign. Once that's signed, then I have these few forms of like patient records. So I call it like, new patient forms that I send to them. And that does things like the privacy policy that they have to read through, telemedicine consent. In the state of Florida, you require pelvic exam consent for females, even the baby. So it has that form in there to give them an idea of the one that they'll be filling out during visits, and also to have a main form in the chart. And it has kind of like who they want to add on the chart as like a person that I can release information to. So I always recommend, like, if grandparents are involved, that they add the grandparents to that. And those are like the main onboarding documents that I do. Then once I onboard a patient, I'll do like a video visit where we kind of go through all the medical history and the family history and social history. And then depending from what I gather there, then we do kind of medical release for where we may need information from. I've had a lot of newborns, so there hasn't been a lot of medical release other than from either the OB, the hospital, or the midwife, which are very easy to get. And for the older patients, most have been relatively healthy, but some that have seen providers, then I just have them fill out a medical release for me to be able to get those records faxed on. And then I use Doximity for faxing, so it's still HIPAA compliant. So if once records go there, then I just upload them onto the EMR.
That's an interesting way that you're approaching medical records, because that is something that can be overwhelming. If you're getting, 13 years of random records from a patient when they're onboarding. I mean, in your case, you're doing pediatric care, so that wouldn't be as much of an issue compared to someone who's doing adult medicine. But I think that that's a great idea to do a targeted approach. Talk with them about their family history, about their social and medical history, and then get information specifically about those parts of their healthcare.
Yeah, I think it's worked well. I will say, of course, I've had a lot of newborns, but at least the families that I've had, they're very well informed. They're very proactive. So they know their child's medical history, like, to the point. They can even tell you, like, the last shots they got, when they got it. I haven't had a family that's been like, I don't remember. I don't know. No, they haven't had any issues. Like, some of the families, like, even things, exams, tests that they've done, they've either kept a record of it as well. So then I'm like, oh, save that copy when I go over. I want to see that, and I'll decide if I need to upload it into the chart. So I think at least families that are geared towards the DPC model are looking for higher level of care and demanding higher level of care. So they tend to be more proactive, at least from what I've noticed right now. So it kind of helps with the whole medical record aspect of it.
Very interesting. And I'm sure that that information is helpful for others who are, again, contemplating this type of model. So thank you for sharing that. We've touched on how you are really building in that early education by interacting with families prior to babies even being born, and working with midwives as well in your community. How do you handle vaccination hesitancy?
I am open to discussing with the families who are vaccine hesitant, and I encourage to do meet and greets. I say a big part is having a pediatrician that you can trust and that you can communicate with. So a lot of the times that is something that we discuss during the meet and greet. And I am very open with the families and letting them know that I am pro-vaccine. I also do not like to push my views. I like to understand where families are from, where they're coming from. Families have different reasons for being where they are at that time. I can tell you from when I've been ill and sick and hospitalized, I have not appreciated when a provider has told me, like, this is what you need to do, this is best for you. So I know that if, that's the language that people are doing, it's automatically like puts a roadblock, right? So like you're already hesitant and you're like, well, I don't want to talk to that person. Like they're already telling me what to do, right? So I don't think that is the right way to approach things. So I like to keep an open communication, and I like to have that be a discussion from the very beginning during the meet and greet. Because if it's a family where like, we can't even talk about this because we keep fighting back and forth, then this is probably not going to be a good match for you. But if it's a family that's like, oh, I appreciate your views, I understand your views, I want to learn more, and I'm like, well, I would love to learn more about why you have your set of views, and we can have those complicated and difficult discussions, and that is a family that I do onboard, because I feel that having that communication, having someone that they can trust, being open both ways, they're obviously wanting to have a pediatrician. They don't want their child to be without a pediatrician. So I think just keeping the communication open is the biggest thing for me.
And for those families who do ultimately choose to not vaccinate according to the recommended guidelines, do you have them fill out some kind of form that acknowledges the risk that they're taking if they choose to not vaccinate?
I haven't had any families that are like completely not wanting to do any vaccines or whatnot. I've had some families that have discussed doing like, I want to talk about an alternative schedule. Or I've had some families that are like, I have concerns and I want to talk about it, but then they ultimately choose to follow the AAP schedule. So I have not crossed that bridge yet, so I'm not sure how I'm going to handle that. I like the form on immunize.org for choosing not to vaccinate over the one on the AAP in terms of the language. So I would likely be using that, but I have not crossed that bridge yet, so I don't know. I like, again, going back to like, I like to understand where the family is at. I think that if a family comes to me like, after we have discussions and they're like, we are not going to immunize, I don't know if like long term we may be the best match depending on, how that communication goes. I would say that's a difficult question to answer at the moment based on where things are right now.
You did a great job answering that. I think it's very fair. What I recall from the last time I looked at the AAP version of the P declination form was it was very eye-opening because
families don't like it.
They don't.
And when you read it through, you're like, I don't know, for me, I'm like, okay, I could see why some families not like it when they're signing that. So that's why I like the one from immunize.org, the language on the immunize.org more.
Yeah. I'm not to make excuses for the system, but it's interesting because it's almost like that AAP form the declination form is geared towards the pediatrician who doesn't have more than 15 minutes max, is going to see 30 patients in the day. And that's something that, covers all legal bases, but it can be administered by a nurse or somebody who's not a physician.
Yeah, exactly. That's why I'm like, So what I actually do right now for my immunizations is that I have the BIS sheet and I go through those with the parents. It takes about 30 minutes to an hour, depending on, the family and what questions they have. But we go through each one of those vaccines. We talk about the pros, we talk about the cons, we talk about pros and cons that may also not be listed on the form. And I have, at the end of it, I laminated them, and then I put, reviewed by Dr. Lastra on, and then I have them dated, and then we sign it. And I do that with everybody. So I don't know if maybe at some point I may just do that, where it's like, we are discussing this, but I do that right now, even with families who are vaccinating, so that that's kind of like a forcing function for me as well, to make sure that I'm properly educating them on everything.
When you talk about the VIS sheets and reviewing those with patients, you also have your own handouts that you've created. Can you touch on these handouts and how you use them with families?
Yeah, so I create different anticipatory guidance handouts that I give to the families, and it also puts their weight, their measurements for that visit, and if they are getting any vaccines, the vaccines that they're giving, and I like to put where they are getting those vaccines as well, so that families know when we're, again, going back to families that I tend to see a little bit more educated, and if they're concerned like, oh, it got red in this area and they're messaging me, we could be a little bit more like, oh yes, that was DTaP that went on there, and that's a common reaction that you can get with the DTaP, so this is unexpected, or yeah, that was pneumococcal, that one it tends to hurt a little bit more. I feel like, every time I touch this thigh, it hurts and he whines, things like that they may be concerned about. I'm like, oh yeah, that's the one that we gave there. Remember, we have it on the sheet. So I also actually put a magnet on the back of it so I can put it on the refrigerator. And it also has some developmental milestones that we look at that we check off during the visit together if the child or baby is meeting them. And I actually take a photo of that and I upload that into the EMR as the anticipatory guidance handout that I'm passing out. And a lot of it is from AAP guidelines on there as well, or like the CDC developmental ones to look out for. And it gives just the parents a more fun way to look at it. I try to make it cute.
And again, coming from a mom's perspective, I actually, I think that's really smart, because when you're so overwhelmed with everything that is required of a parent to take care of a baby, especially a newborn, having something that's very colorful, easy to read, and that has come from your physician, I think is you're bringing a lot of value to your patients and their families by providing this type of handout.
Yeah, I've never liked getting the multiple black and white pages with just loaded up information like, this is how you need to take care of your urine infection. I'm like, oh my gosh, this is too much, it's overwhelming. So I try to just keep it in one sheet, fun, colorful, put it in your fridge so it's always accessible. And it also I also put on it like emergency numbers, so like poison control number, my number for them to contact me like overnight if they need to get hold of me, and those little details. So like if they're like, oh my gosh, my kid swallowed something, who do I call? It's like already there, and they're like, oh wait, Dr. Lastra, here's the poison control number. So like they can just kind of reference that anytime they have a need for something that may be answered to there.
Absolutely. As these newborns grow older, and as your practice has more teenagers, what is the plan if a patient is graduating from your practice to an adult medicine doctor?
So there are some adult DPC doctors in the area. So if they definitely want to stay within the DPC model, I have some connections that I can refer them to. If they're wanting to kind of transition back to the insurance-based model, I have my doctor that I can refer them to. Or I would start to develop, like when the time came. So kind of taking a few steps back, currently with the kids that I have, I think of like what are needs that they need, like ENT, allergy, germ. Those are like typical things that you always have questions on for kids or babies. So I've developed relationship with providers that I know that I can communicate with, that I can text, that if I send a patient, they'll report back to me, or we'll have that kind of communication. So for example, I had a baby that I had to send to an eye doctor, and I had already developed that connection with the eye doctor, and I messaged them directly, like, yeah, my office will contact and make an appointment. So it's not like the family had to wait for a referral, figure out with their insurance, oh, who do I need to call that's covered with this to go see, blah, blah, blah. Right? Like the office is calling them, like, when can we book you in? What time slot we have available? And if they want to use their insurance, they can certainly use their insurance, because there's not a lot of specialists in the area that are DPC. I don't think there are any. So they're obviously affecting insurance, but being able to build that relationship from provider to provider also benefits the patient. So it would be kind of the same going to the teenagers. When I have those patients, and I would work on building those relationships with providers that they would need in order to be able to have that be as seamless as possible.
Looking into your toolbox specifically, is there any tool in there or any other tech that you might not have mentioned already that you use and love?
Yes. So I believe it's called the Rainbow from Maximo, and it's the finger pulse oximeter, or I could do the wrap for the little babies. And you put it on just like the pulse oximeter, you check the pulse oximeter, but then you have to wait for the light to get all the way to the green. And then once you hear the beep and those go out to green, you hit this button that says hemoglobin, and then it gives you your hemoglobin level.
And
so that I like to use if it's a patient who is very, very scared of needles. So if it's any screening work, or if I'm concerned, I definitely prefer to go the blood work route. But if it's a patient, let's say a picky eater, that parents are really concerned, and like I'm really concerned that they may be anemic or something like that, I may not be as concerned based on the physical exam or other things that I gather. That's a tool that I can use to help reassure parents. If it is a patient, again, maybe an autistic patient or someone who's just very hard with pokes, very difficult, that could be a way that we could start with that. And if there's any concerns, like, now we definitely need to get the blood work, or just kind of as a starting one. So I really like the flexibility that gives me to be able to kind of expand a little bit further on what I can do with the hemoglobin.
And do you have a similar tool for Billy checks?
So I currently do not, but I would hope that I can get a Billy meter at some point. I would love to have that. What I currently do is I have some providers in the area that are phlebotomists as part of a company, and they will go out to the family's home and do any blood draws that I need or anything like that for the family. So I include that one home visit for blood draw as part of the membership fees as well that families get, that they don't have to pay for that. If they need anything in addition for any testing that we're doing or anything like that, then there's a charge to have them continue to come out to the home, or the family can just go to any lab and get it done.
For those doctors who are considering leaving fee-for-service or who are looking to start in a direct pediatric care model, what would you advise them?
I would say that first they should look in the area where they're at to see if there's anybody else already doing it and talking to them. I found from the Facebook group that I'm a part of, everybody's very welcoming and very open to discussing in this community about ways we can help each other out, barriers people have encountered, all those things. So definitely reaching out to people who are doing it and talking to them about it. That definitely helped me. So I would say that as number one. And then number two is to not focus so much on the logistics of what you need to do to get it done and overwhelm yourself so much that then you're like, I can't do it because I have to do this and this and that. But more so take a leap of faith if it's something that you truly want to consider. And you may not have everything to start with, but start somewhere and things will come. And the fact that you started, kind of like, Billy meter, I don't have a Billy meter right now. I hope so, but that didn't prevent me from opening, right? So things will come as your practice grows, which is kind of nice to see that you are able to start from potentially very little if you're doing home visits because you don't have like a clinic setting, or other additional expenses that come from a clinic setting. But you can continue to grow on that, and knowing that you've started something kind of also gives you a push to continue to work towards making it grow.
Wonderful. And are there any other additional resources that you like to recommend to others?
The DPC Alliance is also another good resource with lots of good information on their website. I would say that would be another kind of go-to.
Perfect. And what's the best way for others to reach out to you if they have questions after this podcast?
Yeah, they can send me an email at Dr. Lastra, DRLASTRA, and I'm sure you can probably put this on the notes. They notice that. Add head to toe pediatrics, and that's with the number 2. So head, the number 2, toe pediatrics with an S at the end.com. They can also contact me through social media. I'm pretty active on Instagram and Facebook. Add head to toe pediatrics, again with the number 2 instead of TO. Or visit my website and send me a contact there.
Thank you so much, Dr. Lastra, for joining us today.
Thank you for having me. It was a pleasure. I had so much fun.
Next week, look forward to hearing from Dr. Thomas White, Dr. Joshua Carpenter, and Dr. Brianna Buchanan of Hometown Direct Care in both Cherryville and Shelby, North Carolina. Dr. Carpenter is one of the incredible speakers that will be speaking at the upcoming AAFP DPC Summit happening virtually this July 16th to 18th. Visit dpcsummit.org for more information. Also, I will be hosting another free event this upcoming Saturday, July 10th. This time, we'll be doing speed networking and chatting all about DPC. Check out mydpcstory.com for more information. And check out the My DPC Story website for podcast swag. Support the show, get some swag. All proceeds go to producing the show. If you like what you heard today, please leave a review and subscribe wherever you listen to your podcasts. Tell your friends too. For more information on this episode and much more, please visit mydpcstory.com. Also, for the latest in DPC news, check out dpcnews.com. Until next week, this is Marielle Conception.